Good morning and welcome. I will call to order the Board of Health meeting for June 25th, 2025. Do we have quorum, Mr. Ibach?
Yes, we do.
Thank you. And also, do we have any introduction of guests or new staff?
Yes, we have introduction of one staff, Shawn. Yeah, so please join me in welcoming Sophia Lee. She is our environmental health summer intern, comes to us from the University of Washington. And she'll be helping us with our West Nile virus surveillance, so mosquito trapping, our harmful algal bloom surveillance. So she'll be taking samples of surface waters from around the county, and also learning everything we do here at EH and helping us with some of our workflows and procedures, developing those and putting them in writing. You want to tell us a little bit about your background?
Thanks for that introduction, Shawn. I really appreciate it. My name is Sophia Lee, and I'm a student at the University of Washington studying molecular biology and also double majoring in environmental public health. And I'm really excited to work on the mosquito trapping for West Nile virus and also monitoring algae blooms because I'm really passionate about environmental health. And thanks everyone for being here. I'm really excited to learn more from you guys.
Well, we love you. We have guests this morning.
Yes, we have two guests.
Would you like to introduce yourselves first?
I'm Magee Washington. I'm interviewing with recruiters at the Commissioner's Office in the Gabby building.
Okay.
Morning, I'm Dr. Jennifer Maxwell. I'm a family physician. I work at Farm Workers and recently appointed as the co-chair to public health for the Washington Academy of Family Physicians, which is our state professional organization for family physicians. 4,000.
I'll come back and I told you either one if you want to make a statement beyond that. Okay, thank you very much. All right. Mr. Ibach, do we have the written statements? Okay. Then we will move on to consent agenda. All items listed with an asterisk are considered routine by the health board and will be enacted by one motion. There will be no separate discussion of items unless a board member requests, in which event the item will be removed from the consent agenda and considered in its normal sequence on the agenda. Does any board member wish to remove an item? Hearing none, then Mr. Ibach, would you read the agenda, please?
May 28, 2025, the Acton Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in May 2025 in the amount of $1,029,803.17.
I would move to approve the consent agenda as read. I'll second.
So we have a motion and a second to approve the consent agenda as read. All those in favor, please say aye.
Aye.
Any opposed? All right, motion passes. Thank you. Moving on to item 5. We usually have a something special that the staff was talking about here, the spotlight. We're not going to do that this morning. We're going to have a Yakima Health District presentation by our interim health director, Dr. David Atteberry.
Oh, interim health officer.
Oh, interim health officer. Thank God I got the wrong word in there.
Director sounds cool too.
I know.
I'm by no means trying to replace Andre.
Should I be concerned?
Yeah, Andre.
And Shawn, Magee will also be part of the presentation too.
Yeah, so I'll get started on the presentation this morning, and then I'll turn it over to Dr. Atteberry after the first few slides. So today we're going to discuss community water fluoridation, as this has recently, become a big topic of conversation around the country and certainly here in Washington State. You're out of range.
That's down.
Down. Got it. Okay. My tech skills are on display. Okay, so fluoridation in water systems here locally in Yakima County, we're unique. A lot of our municipal systems are serviced by wells, but they still are different than a normal drinking water well. They're much larger. They serve a much larger community. But the breakdown that we have here is we start with individual wells that service a single family residence. We'll have shared wells that have 2 connections, so typically serve 2 single family residences. Then we have our Group B water systems, which are typically for residential purposes 3 to 9 connections. And then anything more than 9 connections will fall into that Group A category. Many of our municipal systems also fall into that Group A category. They're just a much larger scale than Group A water system that serves a suburb or development. So outside of our municipal systems, none of our Group A, Group B shared individual wells fluoridate their water. The only fluoride that can be found in those wells is fluoride that is naturally occurring in our groundwater. So fluoridation here in Yakima County, 7 out of 18 of our major municipal systems are fluoridating water. So they're adding fluoride to the drinking water. In addition to that, we do have low levels of naturally occurring fluoride in the county. One example is down in the Toppenish area. We can find natural levels of fluoride around 0.16 part per million. And to give you some perspective, the optimal levels of fluoride in drinking water for the prevention of dental caries is 0.7 parts per million. So they still have to fluoridate a little bit to reach that optimal recommended level. So state regulations around fluoride or fluoridating drinking water, it's regulated by WAC 246, 290, 460. It is not a mandate in Washington State that public water systems fluoridate their water. It's allowed, it's permitted, and it is essentially up to local communities or municipalities to make the decision to fluoridate their water. If they do choose to fluoridate, they need to follow the guidelines that are outlined in the WAC, which is keep that fluoride levels at around the optimal level of 0.7 parts per million. They have to get approvals on the fluoridation system they want to add, or and monitor regularly fluoride levels to make sure that they're not levels are not going over that optimal level of 0.7 parts per million. So that's what it looks like here locally. The regulations around this from the state, it's basically a local decision, but if a local municipality makes that decision, they need to follow the guidelines outlined in the state Washington Administrative Code. And with that, I will turn it over to Dr. Atteberry.
Sure.
May I ask, can you tell us which cities do you choose to fluoridate?
Yes, I forgot my other notebook at the office, but I remembered all of them except one, but actually found an additional one. So technically, I think it's 8 municipalities fluoridate out of 18. So we have City of Sela, City of Yakima, Toppenish, Wapato, Sunnyside, Mapton, Terrace Heights water system, and it's either Zilla or Granger is the other one. I'd have to look. What's that?
I thought it was Zillow.
Zilla, yeah. But Terrace Heights actually has quite a bit of naturally occurring fluoride, so they minimally add fluoride to their water.
Thank you. And Shawn, you said 18, so we have 18 Group A systems in the county.
18 municipal water systems. Some of them are served by Group A well or several Group A wells.
Cool.
So like City of Mapton, I think has 5 to 7 different wells that serve their town.
So where Shawn was covering some of the regulatory reasoning behind fluoride, I'll cover sort of the philosophy behind the fluoridation of water and or some pros and or cons associated with water fluoridation. Obviously, everybody here probably already knows, but the whole point of fluoridated water, the public health benefit, is that it reduces tooth decay in children and adults, and it does so in a non-arguable fashion. There's 25% reduction in tooth decay in water served with fluoridation as compared to water that is not fluoridated. That is keeping in mind this magic number of 0.7 parts per million. And that is endorsed by the American Academy of Pediatrics, the U.S. Public Health Service, the American Dental Association, various international dental associations. It is considered, fluoridation is considered a safe, effective, cost-effective public health intervention. In fact, some argue that it's one of the largest public health interventions we have of the last century. It should be considered a big heralding success story. There's one important thing to realize when you talk about fluoridation of water is that it's a equitable public health benefit. In other words, the socioeconomic status of the individuals has no impact on if you fluoridate water in a community, you're fluoridating the water for the entire community, and so everybody benefits. Nobody is left out of that. So not all things that we do are equitable, and so it's nice to see when we have one that is. It's cost effective, it's relatively cheap to fluoridate water, and in fact, if you consider the lifetime expense of somebody's water fluoridation, if you broke it down to the individual lifetime cost, is less than a single dental restoration. So it's really a highly cost-effective measure if you consider that we're blocking dental restoration later in life or in children. And as I mentioned, it's endorsed by various public health organizations, including the Centers for Disease Control, the World Dental Federation, the ADA, the American Pediatric Association, to name but a few, but there's many dozen that are endorsing this. So now let's look at some of the cons of water fluoridation. And the biggest one, and the one that you'll read about pretty instantly when you start researching this topic, is something called dental fluorosis. It's a relatively insignificant problem in which you get some white spots on your teeth associated with increasing amounts of fluoride being absorbed, mainly in children. Its incidence is reported all over the place in different levels, but kind of a standard level is considered about 12%. If we use the 0.7 part per million, severe fluorosis is rare, and it's very rarely, if at all, seen at these levels of 0.7. When you read about incidents of severe fluorosis, it tends to be in areas where there's a much higher natural occurring source of fluoride in the water. For instance, if you go worldwide, China and India have almost 3 times this amount of naturally occurring fluoride in their water supply, and therefore the incidence of skeletal fluorosis, which is a much more complicated and pathologic condition, is seen more commonly in populations such served by those water sources, as compared to the U.S., where no water supply is getting those kinds of levels. The highest water supplies I saw in my research, I think there was Colorado Springs, Colorado had a pretty high concentration of, if you took that 1.0 from the 0.7, so it's naturally occurring at a higher level than we would recommend. And obviously, if that's the case, you don't have to add fluoride to the water, it's already there. There is no public extraction policies in place, but some families and individuals do that. Again, that would not necessarily be equitable, though, because you have to buy things to do that with. So then you get into the ethical and public acceptance issues, and some groups argue that water fluoridation on ethical grounds is akin to mass medication of the public. I think that's a hard sell in the sense that fluoride is a relatively benign substance. And so when you start talking about mass medications, you're talking about something that is not benign, and you're giving it against people's consent. Obviously, you don't consent to the public water systems, and so there is no medication in that regard. However, that's some of the argument put forward. And then there's the perceived controversy, and all of us are aware that if you go on social media and you start going down rabbit holes, you'll find lots and lots of information that seems rather horrifying. When you first read it, you say, well, gosh, that seems awful. We should immediately make that illegal. And then as you do more research, you say, well, there's biases and lots of reporting. Some science is more robust than others. And so I think what we all have to do as public consumers of public health, and especially as policymakers, is take into consideration, what is the source? What are their biases? Is there a marketing kind of gimmick here? For instance, many of the things that I read that were on the more horrifying side were then supplementally backed up by pages of ways to extract the fluoride from your body. And so you're like, well, they're selling us something here in this arena. But nonetheless, I'll get into some things that are not like that. But I'll just say that many of the things that I saw that were really strongly anti-fluoride seem to have almost a marketing basis to them. But nonetheless, that's my opinion, not based on scientific fact, just what I was reading. Persistent public debate, though, and misinformation is out there. And so we always have to be careful about that, specifically in relation to cancer, neurotoxicity, and then There's gonna be a paper that I bring up in a minute here that goes over some decrement associated with childhood IQ scores and maybe even adult IQ scores associated with higher fluoride levels than what we're recommending here at the 0.7 part per million. And even that data, which I'll get into, I can point out some issues, maybe that they're drawing conclusions that you might not want to draw, or that the data is not powerful enough to draw. It wasn't designed in that way, but I'll get there. Implementation challenges. Obviously, anytime you have implementation of doing something to the water supply, you have to face political opposition, cost, infrastructure, and monitoring requirements, and that creates cost. So with that, I tried to break it down into the current Washington State issues and then the current federal issues related to the water supply. And here was the key take-home messages. Washington State DOH is aware of a newly released National Toxicity Program Review, which is a division of the Health and Human Services, critically examining the use of fluoride in water. And I'll get into that. It's a manuscript that is available online and everybody can read it, but I would tell you to set aside some time. It's 374 pages. There are some summary pages in there that are about 3 or 4. However, it's quite dense and long. And I put it next to my bathroom for bathroom reading. I've gone through the first few chapters of it, and I can tell you, interesting. We're also aware of a recent federal district court. This is probably more relevant when you start dealing with district courts. In California, there was a lawsuit involving the EPA in which a district judge said that based on really some of the data being presented by the NTP, that we should take a second look at the fluoridation of water because maybe there are some health risks. However, even that judgment did note that the levels being discussed at the level of, well, I'll say pathology and the level recommended for public water supply are different thresholds. This particular judge's ruling suggested that maybe those two thresholds are too close together, one being 1.2 parts per million, the other one being 0.7 parts per million. But still, there's a significant difference there. Evidence shows that community water fluoridation at optimal levels prevents tooth decay, and that's not arguable. I don't think anybody would argue that, and promotes oral health in children and adults, which in turn promotes general health in children and adults. As we all know, your oral health has a direct impact on various other systems in your body, most notably cardiac systems associated with cavities and oral bacteria. So background on the NTP review. So since this is going to get all the attention, I want to spend some special time paying attention to that. The National Toxicology Program, which is a part of the Department of Health and Human Services, released this monograph on the state of science concerning fluoride exposure and neurodevelopment and cognition. And it specifically was looking at fluoride exposure and whether or not it can be associated with lower IQ in children. Now, I want to make sure I point something out. When you design a study, or in this case, this is a meta-analysis, and anybody who's not familiar with that term, meta-analysis take lots of published literature and they compile it. So in this particular meta-analysis, they took 75 published reports, and then they look at those and they say, well, what data in these reports can we aggregate, can we draw from, and then what data should we exclude? And so the first thing I'll point out is, when you set up a meta-analysis, you have to set it up around a question of what are you trying to answer? And at the very beginning abstract of this paper, they specifically say, this is not designed to determine whether or not IQs are being decreased in association with fluoride in the water. That's not their design. And so when you start making extrapolations of you see, you're like, well, that's not the design of that paper. And in fact, they point out to you specifically that it's not the design of that paper. The paper was simply to look at the published literature and is there trends that we can see in the published literature that are suggesting that there might be something that we should look at further. And I think that's relevant, and I think all science should do that. We should look at what we're drawing from conclusions and say, well, can we extrapolate from conclusions more data? And with that, can we set up more research where we start asking those questions specifically? And can we power a study that would suggest the outcome can be measured? That's the trick when you're doing research. can you find a difference between two populations, and can you control for all other variables to where you can extract that this difference is being drawn from these particular variables that we're looking at. It's a very important fact because I think a lot of people who came from the quote literature are reading and saying, well, whatever they say is gospel fact. And you're like, well, no, not necessarily. What they're telling you is what they were studying. And you have to always ask the question, whenever you read any research paper, what was the question they're asking? Here, it was, can we look at 75 published papers and draw any conclusions from those? And the answer is, yeah, there's some pretty interesting data there. The DOH is currently reviewing the newly reduced review, so at the state level, we're not ignoring any data. I should say the state is not ignoring any data. They're looking at it, and they want to continue to look at it as more data comes forward. So next, when we look at assessment, the NTP monograph does not find harm associated with current recommended levels for optimally fluoridated water at the U.S. Public Health Service recommendations. The monograph found possible harm statistically associated with naturally occurring levels of fluoride that are more than double the amount used in community water fluoridation, but did not determine that the fluoride is the cause of the harm. And so one thing that's interesting in these studies, several of these studies, I think almost 14 of the 75, were from areas like China and Asia, where the fluoridation levels were inherently higher. And so that right there would be a biasing factor that you would say, well, hey, listen, we should maybe separate out or aggregate out that data as you're not comparing apples to apples now. Finally, the monograph found possible harms, the monograph emphasized that it did not address whether exposure to fluoride added to drinking water is associated with a measurable effect on IQ, nor does the monograph assess benefits of the use of fluorides in oral health or provide a risk-benefit analysis, which is another way you can look at that same data. You can design a study around the risk-benefit, and then you make weightings of your statements. So, background on the EPA ruling now. The EPA assesses safe levels of additives to drinking water for health and sets standards to protect communities under the Safe Drinking Water Act. The EPA sets limits on what is allowed and what is recommended. Fluoride is but one such example. Fluoride is an element found naturally in water and may also be added to the water by drinking water systems, as we're discussing here, to promote strong teeth and to prevent tooth decay. Food and Water Watch, an environmental nonprofit group, and several anti-fluoride groups, including the Fluoride Action Network. That sounds like an exciting group to hang out with, the Fluoride Action Network, challenged the EPA in court, and their petition to ban water fluoridation was denied. It was denied by the EPA in 2017. This is the basis of the lawsuit that they filed. The EPA, they originally put an argument before the EPA, and the EPA told them no, and so they turned around and sued the EPA, and that's where you get this district court ruling. And it's very recent, September 24, 2024, the finding against the EPA ordered the agency to take action to further evaluate possible health risks from recommended fluoride levels in the U.S. drinking water supply. The judge's ruling heavily cites information from the NTP review, and it was released in August just before that judgment, and concluded that higher levels of fluoride can be associated with lower IQs in children, and that is actually true. The NPP monograph clearly stated that it does not address whether fluoride in the drinking water's recommended levels of 0.7 is associated with an impact on IQ. Nowhere in its decision does the U.S. court order the EPA to ban water fluoridation, and the EPA may issue a new rule or might appeal the decision, as is the case with all legal matters. So we get to community water fluoridation is safe and effective. Right? And all statements I'm going to make now are based on the current data that we have in the published literature and what we know, that we would characterize water fluoridation as a safe and effective means to decrease tooth decay at this specific level, 0.7 parts per million. And that is endorsed by the CDC and various other public health authorities. For over 80 years, public water systems across the country have adjusted and existed naturally occurring fluoride levels and to the drinking water to make an optimum concentration to try and hit that 0.7 number. Today, even with widespread activity of fluoride toothpaste, Studies show that community water fluoridation continues to be effective at reducing tooth decay by as much as 25% in children and adults. National health organizations such as the AAP, the ADA, World ADA equivalent, all have endorsed the fluoridation of water systems. So where are we at right now? As of 9/25/24, Washington State Department of Health is taking a kind of a hold while they look at, quote, new data that's being produced. And they said they will make a decision as new data comes in, which seems reasonable. They're taking in new data, and we're gonna look at that data and see whether or not anything points to something that we should be concerned about, because obviously nobody wants to cause harm, IQ decrements, or anything else to children. And if we look at our current school numbers, I would suggest that they're already having a hard enough time as it is. We don't want to make the situation any worse. So that's an important thing to consider. Community water fluoridation at optimal levels continues to be a cornerstone strategy for the prevention of tooth decay. It is practical, it is cost effective, it is equitable for communities to improve the residents' oral health regardless of age, education, or income. Now, as far as the EPA's ruling and where Washington State lies there, the Washington State Department of Health is working to assess the science, obviously, we just said, and the district court has not found that with certainty that fluoridated water is a risk to public health. They have concluded there's enough risk of injury to trigger an EPA action under the Toxic Substances Control Act. And really all they're asking is for more research to be done, which seems very reasonable. The finding defers to the EPA's expertise on how to evaluate and regulate fluoride in drinking water. And the EPA is working with the Department of Justice to figure out the next steps going forward. In conclusion, water fluoridation is safe, effective, and equitable public health measure for reducing dental caries with mild dental fluorosis as the primary adverse effect at the recommended levels. Ethical, political, and public perception challenges remain significant considerations in the discussion. And for that, I provide everybody, and you guys will get a copy of this already, with references, which is all the papers that I'm citing, and including the monograph, so you can read it yourself if you have some free time. With that, I open to questions from anybody on the board or guests or whoever. I can ask questions for.
Quick question. If you like install filtration on your home, does that filter out fluoride, or is fluoride not?
I think there are particular filters that can filter out fluoride. You all have to look at the particular manufacturer, but yes, they exist and the ability to extract fluoride from water.
Right on. And then the wax, do they specify other things that we're allowed to add into our water, or is it just fluoride that?
They'll talk about chlorination and how to remove minerals or heavy metals from water. There's specific sections on all those things.
There's also pH balancing that they do to water to balance. Anything else?
I was just going to say, I want to thank you for the report. I thought it was thorough and balanced. You looked at, obviously did a lot of digging on it. I just want to know how to join the fluoride action.
Yeah, that's something to talk. I don't know when they meet next, but I certainly, get in my area, I'm going to go.
We won't allow you, LaDon. We're going to hold you back.
You're going to save me from that?
Yes.
Yeah. Probably an exciting group to hang out with and drink coffee, I guess. Yeah.
I had a question.
Please.
Tony Sandoval, I thought your meeting was over here. I was already.
Sure.
And then there was no signs there or anything to find you guys. So I pick up behind a little bit. So why is Pasco moving on this fluoride stuff?
I'm sorry.
Pasco, city of Pasco is moving on this.
So I don't have any opinion or direct knowledge of what Pasco's doing, but I know that various municipality organizations are having votes. If I gave this talk even 4 months ago, I would have told you none of the 50 states have any prohibition to adding fluoride, and now Utah and Florida both have illegal to add fluoride in their states respectively. Maybe other states will join that, maybe not, but each municipality, that's the issue. You're going to end up with 5,000 different decisions in 5,000 different communities. So you're not going to have a uniform thing because the regulation of the water is done locally, not necessarily on a state by state basis, unless the state has an action that requires compliance.
So, you did this presentation in the health district over there, or does this health district cover Tri-Cities also?
No, Yakima County, sir.
So there's a different health district?
Correct. Ben Franklin.
Okay.
Ben Franklin would be the.
So apparently they listened to something there and are moving on. From what I understand, they're moving against fluoride.
Yeah, well, that may be, Mr. Sandoval, but it is not relative to our discussion today, because we're talking about the Yakima County Health District.
Right, well, so I didn't know what how it's shaped as far as the health district, but yeah, you did answer my question. Thank you, sir.
Thank you.
You're welcome to stay.
Oh, yeah, Mr. Senator, also local municipal systems, city systems, they get to determine. So health departments don't determine the fluoride.
You just put out the education or status,
Right.
like he's talking about.
We're trying to put forward data, and then local municipalities make their own decisions.
Okay,
Yeah.
thank you.
Please.
Yeah, a couple of things. So I just was curious if, if you've read or heard anything in the studies that were done or talk about future studies, if they're going to take into account like the cumulative amount of fluoride that people are getting, because if it's added to a system and, and they're using toothpaste and there are other products and things in our lives that have fluoride in them. So how are they going to parse that out?
So it's a challenge, and what I read about so far is there's not great cumulative data scans, if you will, for fluoride. There are a few scans out there that can do various nucleotide scans that will show you how much fluoride you absorb, but there's no standard by which to compare those two. And that's what you run into, is when there's not a standard, you say, well, you can measure it, but you're just measuring it blindly. So unless you set up a study to say, well, let's measure this population, let's follow them out throughout their life, and then let's see what happens to them in the end, then you might be able to make objective decisions about how much is too much. I do know this, that probably it's overkill to have fluoridated water, fluoridated toothpaste, fluoridated mouth treatments for your kids. Probably any one of those would suffice. However, parents are just saying, well, fluoride good, more fluoride better. Maybe not. I don't know the answer to that, but I think that the various entities with interest stakeholders, like the American Dental Association, like the American Academy of Pediatrics, will certainly be setting up studies to try and answer some of these questions, because I think they are fundamental questions that deserve an answer, that warrant, when you're talking about something as drastic as, is it reducing the IQ of children? Everybody's going to get the attention there and say, well, hey, we should know that, shouldn't we? And the answer is, yeah, we should. However, as you'll find, like so many things, it's very hard to set up controlled studies in which you control for all variables and then be able to make statements. If you can do it, you can make these powerful statements. However, oftentimes you can't, and we're able to just simply say, well, based on the data we have, here's our recommendation. And I think that unfortunately, and the reality is this, our courts tend to drive more of our public discussions than probably they should. And therefore, it's not the scientists that are doing it, it's the lawyers. And that doesn't necessarily, that can skew your outcome quite considerably depending on who are the lawyers, who are the judges. But I do think that it's something that we should, as a public health, stay at the forefront of. We are, and all of us in this room and everybody who works in all these counties and organizations, we are the experts at trying to help answer some of these questions. And we should at least be putting our foot forward to say, hey, can we help you answer this? Can we help in extracting this data? Can we help design some of these studies? Because that is critical. If you don't have, the old saying, if you're not invited to dinner, you are the dinner. That kind of goes to that. So you want to be invited to the dinner and take part in these studies, please.
With regards to fluorosis, is there a remedy? How do you treat it? How do you remedy? And in the event that it is occurring in these municipalities that have it in their water, is there liability to those municipalities to pay for such treatment, et cetera?
I don't know any, as not being a lawyer, I don't know anything about the liability that they would face. I'll defer that to various lawyers that might argue that or answer that for you. As far as fluorosis from the fluorosis of the teeth, the staining of the teeth, that is a simple cosmetic laser peelings and various things they do to extract that. If you're talking about skeletal fluorosis, which is a much more damning or considerable health concern, that becomes a lot more challenging to say how to extract it from skeletons. We don't know the answer yet. We also don't know the pathophysiology of how it deposits or how to extract it. So answer that question that way.
Okay. So I was hoping you would kind of get into more of the history of it and especially the difference between the industrial byproduct, which is typically what is added to the water systems versus the naturally occurring. Because if I understood correctly from the little bit of research that I did, the initial observations for the benefit was based on the naturally occurring fluoride.
Yes.
Which is much different than the byproduct. And those are what I think the big issue is. It's not fluoride in general per se, but that this is industrial waste essentially.
Sure.
And that is what is really seen to be the biggest harm.
So I think that the most important thing, and I think that the controlling variable is that 0.7 parts per million. If the fluoride is driven to that level, we can make statements generically about at that level it seems to be safe. If the fluoride is naturally occurring at higher levels, like for instance China, where it's almost 2.1 at baseline, that's a higher level than we'd recommend. And if you're adding to that, that's problematic, probably. Although I can't make that statement either because I don't know that. I'm suggesting that the data would suggest that. Because of the limited time of the presentation, I guess I couldn't go into all aspects of the history. With that said, I think all history of public health is fascinating reads, and I would recommend to anybody, grab a book on public health and you'll find the history of public health to be one of the more fascinating topics out there. For instance, we were just at a Semiamu retreat for the Wasalpo. They gave us a book there. Tuberculosis is everywhere. And what I learned in reading that book in the first few pages is that 1 in 7 humans that ever lived on this planet have died of tuberculosis. If that isn't fascinating, I don't know what number might be. So the history of public health is the history of history. And it really is fascinating. I would tell everybody, read as much as you can, be an avid student, and just absorb all you can because it truly is fascinating. With that, the rest of the time.
Thank you.
Yeah, I appreciate that. May I'm so sorry. Just may I follow up, please, if you don't mind?
Please.
Daleen, you've referred to it as industrial waste, so I've not heard that before. So I'll ask Shawn to figure that out. I mean, there's naturally occurring. I would assume that's in rock formation. I don't know how difficult that is, so I'm sure it's extracted in some sense and manufactured by professional organizations, but we can certainly look into that. So that's something that you've mentioned. Again, it's the first in my career I've heard it referred to. So that's something that we can bring up, and in your presentation, Shawn, next month, if you don't mind, we can address that.
Well, I would just like to say, I mean, just you were admitting that there's so many variables and there are things I think that they haven't looked at and intentionally haven't looked at. I mean, with the history of it, what sort of drove it to become the new snake oil was that aluminum companies were getting sued by people around that area that were having ill effects from the waste, which was highly fluoridated. And so anyway,
If you
like you're saying, all the studies don't show us for sure. We need to know more. So I think that in itself is an argument that we shouldn't be saying it's safe and effective because you're admitting we don't know that it's safe and effective.
Well, I guess I would just coax it and say, with the data that we currently have available in the published English literature, it's safe and effective. As we get more data, I reserve the right to change my opinion if the data would suggest that I should. So I think with the current published data, that's an important distinction because anybody can make any statement, but if it's not backed up by data, you're like, well, it's just your opinion. I don't know how much to weigh that against anything. Not to downplay anybody's opinion, simply to say that we don't take opinion and put it against scientific data and say, well, these are equal. Well, no, they're not equal. One is rigorously analyzed, and the other is somebody's opinion, which could certainly have biases. And I don't know that they're biases, I don't know them. So I just know that whenever bias, I mean, one of the bedrocks of anybody who's done an MPH, they'll tell you is analyze the bias. Anybody who does research, analyze the bias. If you look to yourself, analyze your bias. We're all biased all the time. Every one of our decisions is biased by our experience, biased by what we know, and even in part biased by our ignorance. And our ignorance is always what gets us. So what you don't know is usually what can harm you. And I'll just stick to that. I'll say, well, here's what we know right now on this date with those slides I threw up there. And I'll say that in the future, we might know more, and we will certainly keep this on the forefront of our topic list because everybody else will as well.
I think it's also important to make sure we know the liability for municipality. If as a board, we make any kind of recommendations, we need to know what the liability is for those communities. If somebody ends up with fluorosis, are they the ones that are gonna end up paying for the laser treatments, or is that not on them? And there was a question in the back.
Oh, please.
Oh, thank you.
You're welcome.
First of all, I just want to say thank you, Dr. Atteberry. I think it's very thoroughly done. I also just wanted to add, as a family physician working at a federally qualified health center, I do see all the time children who do not have access to fluoride treatments, who do not have access to toothpaste. And so this is very important as an equitable measure that has prevented a lot of decay in children. My question is, do we have data specifically, since this is a local decision and a municipal decision, do we have data here in Yakima and compared to other counties that may be similar to us? Because I would hope then that we could see a difference between us and Florida and other ones that don't. And so that's what I'm curious about, because I don't actually know the data on it.
So I don't have,
Let me make a comment here, because the discussion could go on for a long time. The fact is that there's a lot more research that needs to be done. And so thank you, Shawn, for bringing back next time some information that was asked about the fluoride. And thank you, Darlene, and I'm gonna try for your questions. And Darlene, if you would like to provide some links to research that you have that maybe Dr. Atteberry could look at, I think.
I already did.
I
I sent it to him already.
Okay, thank you. Okay, good. And thank you, Dr. Maxwell, for your question as well. These are questions that don't have an answer right now. There's obviously a lot of things that need to be looked at into the future. We're not going to settle that today. So,
if I just might add one last thing, and then I'll back to the though I don't know of anything comparing Yakima to similar sized counties in Washington, there is a province in Canada that took fluoride out of their water, started seeing a dramatic increase in dental caries in the following years, and then resupplemented the water with fluoride and started to see it decrease. So that is what we call a natural history study, where you follow the same group, you put different variables in, and then you saw this fluctuation. It's fascinating, and I think it's an area for more research.
thank you, Dr. Atteberry. And thank you for all for your questions. And input. We're going to move on.
Thanks.
Yep. Okay, next on the agenda is agency reports. We're going to start with Executive Director Fresco.
Thank you, Mayor Byers. Thank you, Dr. Atteberry and Shawn, for the presentation. Good morning to the board. I wanted to begin by saying that I've been saying for months that we did not have a decision made by the governor regarding the Secretary of Health that we do now. Dennis Worsham is now the new Secretary of Health. His first day will be, I believe it's July 1st of next month. So he will officially take that position. Dennis is a colleague of ours, has been working in the state for decades in public health. Has worked in the Snow Homes Health District, most recently as administrator. He's worked for the State Department of Health, Seattle County. He's well respected, and the governor made a choice to select somebody and appoint somebody who has local health jurisdiction experience. So we welcome that. He will be taking on a great responsibility in the fact that there are significant cuts both to staff and to budgets at the State Department of Health, as we're seeing around the state and other departments as well. So that's complex. But I did want to share with you that that will bring some security to the process. And certainly his whole understanding of how local public health works is going to be beneficial to us here. He also grew up in Othello, so it's not a vacation town. it's a serious, hardworking agricultural community. So he understands the complexities of a community like ours, and certainly continues to visit his parents in Othello. So he understands what we go through on a daily basis. So I think that's to our benefit. I wanted to share on a financial level that there have been changes to some of our funding. You'll hear from some of our staff over the next few months from our directors about changes perhaps to programs, but we've discussed the Foundational Public Health Services funding that we receive that's received statewide by from this legislature to the State Board of Health, tribes, local health jurisdictions, and the Department of Health. There has been a reduction in that. That equivalent, though, to us is going to be 2.5% of the money. So it's under $100,000, which we planned for, have been planning for the last, I'd say, 8 months in terms of reduction. So I'm actually pleased that it's not significantly less, or rather more. Sorry. We anticipated harder cuts. We anticipated more dramatic cuts. That has not happened. So in terms of public health in this state, the legislature remains committed, and our budget is strong. Our ability to provide for the community and for staff remains strong. So I don't feel apprehension, but I do want to remain vigilant. And Chase and I have been working with our teams to really discuss how we can maintain our fiscal strength in this period of uncertainty. So we're doing well, but I didn't know if the board has any questions on that. We are watching as cuts at the Department of Health have impact to the work that we do. I just learned yesterday that there may be regional cuts, I believe, to Department of Health regional offices. And so those regional offices may close, which means that we won't have access to people in Eastern Washington the way we normally would. We've worked hard at the health district to promote the benefit of having staff in the field from the State Department of Health, having more presence, if you will, in Eastern Washington specifically. That's been beneficial, but I think that time of budget cuts, they're closing those offices. Doesn't mean those individuals are going away. They'll work remotely in those areas, but that is a change. We're also seeing that the cuts at the State Department of Health are impacting who is in what position. So there's a great deal of bumping or movement within the State Department of Health, which creates destabilization. In the midst of the new governor, destabilized budgets, loss of staff, and a new Secretary of Health, that doesn't make for the easiest communication for our team. That doesn't mean we can't get the job done, but it does create complexity for our staff. So that's not an excuse, but a reality that we're in changing times. And so we have to work harder here at the district to make certain that the needs of our community is met, which we're doing. But I did want to sort of illustrate behind the scenes that it's not as simple as it used to be. That's it for me, unless you have questions.
Questions? All right, thank you. Thank you. Thank you, Mr. Resto. We'll move on to Chief Operating Officer Ryan Ibach.
All right, so the remodel of the Acton Health District building continues to be on schedule and under budget. It's been a very pleasant experience. Our architect, KDA architect, and our general contractor, M70 Construction, did a great job.
No, he's really not joking. It has been closed.
Yes.
It's not-
Yeah,
it's
that
not-
wasn't sarcasm. No, it's
not
good.
sarcasm.
Yeah,
It's
Well,
really
it
true.
comes in under budget, that's.
yes, exactly.
Well, that
Yeah.
part's certainly plus.
And exceedingly polite.
Yeah, and very concerned about, not interrupting services and making a lot of noise, for customers and for our employees to continue to do the work. So the first phase will be done the end of July. So we will be meeting here again in this Department of Ecology building for the next meeting in July. And want to thank the Department of Ecology again for allowing us to use their conference room. We also are in the middle of contract negotiations with both unions. We have 2 unions at the Acton Health District, so we're hoping to have those wrapped up at the latest by the beginning of September, but hopefully sooner than that. We also continue to monitor for wildfire smoke impacts and emergency power de-energizations. And at this point, there have been no de-energizations yet. However, we do have a hot spell coming up next week, and it's the 4th of July, so that's kind of when we're in full swing. Monitor that. And like I said, with the hot weather coming up, we continue to monitor the weather forecasts along with the Yakima Valley Office of Emergency Management and Services.
The 2 union contracts, this board doesn't approve or modify it. It's on
Right.
your guys'. Okay.
Yeah, and we just make sure that we operate under the budget that this board approves.
And we also have counsel both for regular health district affairs and specifically for union.
Any other questions? Thank you, Mr. Ibach. Appreciate that. Now our financial report from Jay's board.
Good morning. Report starts on page 9 of the packet and it will be up on the screen. We're reviewing for the month of May. We had a loss of 202,000 for the month of May. Can you zoom in just a little bit? They're hard to see. Our allocated budget for revenue is about 5.6 million. Our actuals coming in at 4.3. And for expenditures, 6.5 million allocated budget, and currently closer to $5.2 million. So we are underspent in expenditures by approximately 1.4 million during the month of May. Next page, please. Looking,
Chase, if you don't mind me asking a question, do you anticipate that trend continuing as far as the expenditure rate?
no, I actually will expect it to uptick here in the next few months. We haven't reflected any building costs quite yet.
Okay.
So yeah, so that will, I do expect this to remain under budget for our staffing and among other things. But yes, no, that deficit will decrease as we start to get more building costs. We'll start seeing that for the month of June. Yeah. Moving into the next page in the income statement, the glaring difference here is for foundational public health. Came to a contract end at the end of last year. So they fully funded $3.8 million in 2024, which we could use into 2025. We will get another funding round here in July of FPHS, and as Andre indicated, it was the cut is not as dramatic as we were expecting. So we were actually very grateful for that. Our expenditure deficits continue to be in our payroll expense, as well as our enhance and our capital. Our enhance and our capital are our main funding sources for the building. Unless there's any questions, I'm not going to really speak to anything else on this page. Yes, sir.
Chase, thank you for letting me add that we had anticipated in this budget year being able to pay for the local buy-in, if you will, from the Emergency Operations Center, which would have decreased our enhanced budget significantly, but that didn't happen. I understand that that's still a consideration, but it would have changed our.
Yeah, I believe we budget around $250,000 for that. Yeah. So that is, yeah, not going to happen. Unfortunately. Moving into the next page, what I would like to point out here at the bottom is the FPH funding that we are carrying forward from 2024. We have through the end of May expended 1.7 million of that. We still have 335,000 or 336,000 of FPH expenditures through the end of June. As we do plan on using that. Is there any questions on the income statement? All right, moving into program specific. I have no real comments at the moment. Our clay section here is our FPHS, which makes up a good majority of our funding here. And the differences for all of these is due because we received the funding in 2024. Moving into the next page. Continue to see a loss in TV, but we've had just an uptick in cases for that. And moving down into EH, spring has sprung in EH, and we're starting to see some gains in some programs that we've seen losses in. Last page, please. And our water project continues to be an emphasis for our EH program. Any questions on program specific? All right, moving into the last page of our report would be the cash flow through the end of May. We have $15.4 million in cash and cash equivalents. I do expect that to tick down in the month of June. There will be, because we do have some expenditures for the building and things like that going out. But I am expecting an uptick in the month of July though, when we receive that PHS funding. Any questions? All right, that concludes my report. Thank you.
Order, we'll move on. Down to our health officer, Dr. Atteberry.
Sure, thank you, Madam Chairwoman. So for the health officer report this month, I chose 5 just quick bullet point topics, all of which have relevance to us here. Obviously, number one, we're seeing a rise in the COVID-19. It's now 5 years wiser, 5 years stronger. Nimbus variant is what they're calling this. It's a mutation of the spike protein NB1.8.1, so we can translate that. The spike protein is what allows it to enter the cells basically effectively, so it makes it more contagious. It's dramatically increasing in Asia and Europe with that Omicron variant. We have not seen yet that same spike in America, with the exception of California, where 40% of the new isolates are that variant. So California, yes, the rest of the US, no, not yet, but probably soon to follow, as that's what we typically see in the migration pattern for COVID. COVID, as you know, has 2 spikes that we tend to see throughout the year, a wintertime spike and a summertime spike. So we're probably entering our summertime spike associated with it. Still, the best I guess, antidote or way to avoid COVID is through vaccination, and there's still recommendations for vaccination. If you're elderly, if you have pre-existing conditions, or if you're children with immunosuppression, those are groups that are specifically high risk. And so those are considerations that should be made. Obviously, probably just taking common sense though, if you're sick and you have a cough, don't go to work, don't spread it around. Try and isolate yourself, stay at home. That's good common advice for anybody, for any disease. I guess I can make that statement. So I'll continue to say that. Number 2, heat index is going up next week, as we mentioned. And so that's particularly vulnerable to our older population, where heat exhaustion, heat stroke, and dehydration are all major real considerations. And so just keep an eye out for your loved ones, for your elderly, for your children, making sure they got sunscreen, making sure that they're getting plenty of water, and making sure that we're staying out of heat. While we're on that same topic, next wildfire season we're in the middle of, and next week is July the 4th. So let's all be intelligent and not put fireworks into dry, patchy chaparral areas where fires will start, as that is known to happen on an annual basis. I will pray all week for Magee and see how they do, but every year I'm always shocked at the what looks like a war going on in the Magee.
They're requiring to make some Magee City edition.
Okay, good, yeah. Right. So
You can pray for Sunnyside too.
right, all the not everybody, right? But I guess
They opened up their policy last year, and it was nuts.
When
They're requiring permits this year as well.
exactly. I would just tell everybody, when it's extremely dry and extremely hot, be careful what you light on fire. That's a good general. And then if the wind picks up, really be careful. So, those are generally good advices for anybody. No Nobel Prize winning statement there. Let's see here. Finally, next, and probably most importantly and pertinent to us, tuberculosis continues to be a vexing problem in our valley. It is a challenging disease to both treat. It's manpower intensive. It is drug intensive. It is hour intensive. And I cannot thank Melissa and her team enough for the just hard work that they're doing to control what would be an outbreak by any definition anywhere else. We are containing it. We are seeing the numbers stay steady, and we are treating those people most effectively. So that's the most important thing, is getting people to treatment. When you think of TB, I want you to think of one thing: where the drugs exist, the disease doesn't exist. Where the drugs are absent, the disease goes rampant, and in poverty, it goes rampant. So those are the take-home points for TB. It is a disease of the isolated, and a disease of the poor, and they carry the lion's share of the burden. So anything we can do to lessen that burden, we will do. But her team and myself, we're doing just absolutely amazing work on a daily basis. If any of you guys could see it, you'd be amazed how much work goes into one patient. And we're following about 30 right now, so all intense. So with that said, we'll keep it up and hopefully see some decrement in the numbers. The problem, the reason why you don't see that quickly though is some of these patients require treatments for 9 months, 6 months, 1 year. It's a long-term treatment, so it's not just getting them antibiotics, it's getting them antibiotics on the daily for a year, and that's where the challenge lies. And it never fails. They're in the middle of nowhere where they get this. So you're like, well, how are we going to get that? How are we going to see them? How are we going to get to them? It's just a real challenge. It's a real challenge that we face. Finally, next bullet point, measles. Obviously, the best way to avoid measles is vaccination. MMR, 2 shots. Always get your 2 shots. You may need a booster as an elderly, though that hasn't been fully sorted out. I will say that vaccination is the best way to avoid measles. And the reason why we're seeing uptakes in measles burden is because of a lack of vaccination. I'll state that again. The reason why we're seeing an uptake in measles is a lack of vaccination. So take home point there. And then finally, there was a rather large egg recall in California and Washington. However, Yakima County, I didn't see any eggs recalled locally. But salmonella is in some eggs that are widely distributed. And as we've said over and over again in these meetings, I know I've sat through it, Dr. Barr described this, but with our national distribution of food, the way food is supplied around the country, small problems get to be widespread problems in multiple states very quickly. That's not necessarily the problem was that big, it's that small factories distribute widely to many states. And so when you get a problem in one place, you see it everywhere pop up like a wildfire. So just keep that in mind. You'll probably keep seeing that theme because the consolidation of the food industry continues to take place. So I don't see any reason why that would change, even though our practices, best practices are staying the same. So with that, I open to questions.
Dr. Atteberry, if you don't mind, Shawn, when it's your turn for the report, could you just add the tracking that goes on in terms of food distribution? Because we benefit from awareness of the national food chain. So thank you.
Yes.
Any other questions? Thank you, Dr. Alvarez. We will move on to Melissa Sixberry with disease control.
Thank you. Good morning. Just to follow up on the active tuberculosis cases, we have 15 cases for Yakima County that are currently being managed. 7 of those are being done by Yakima Health District, but we do have a lot of oversight with the Indian Health Services that monitors their patients. But that we also, in addition to that, have what we call Class B. So these are immigrants coming in screened for tuberculosis, who we have to then rule out for active. We help them get treated for latent TB if they don't have active disease. So that's a lot of what Dr. Atteberry is talking about as well, in addition to this 15 cases. It is very.
Sure. So I know we talked about it last month, but the treatment is extremely expensive for the health district. We don't get to send a bill to the state or anything and get recouped because some of our folks aren't able to pay. They don't have insurance necessarily to pay for the treatment, so it's on the burden of the health district. That's just a fact.
There's a lot of variables, so it's actually up to the counties. So the health district receives up to $150,000 a year from Yakima County to treat tuberculosis for Yakima County. We also receive some funding from the State Department of Health for tuberculosis. It's about 25,000 or so.
That's not a lot.
Yeah, it's not a lot. And then also anytime we can bill insurance, we don't bill insurance we don't bill insurance at all at the health district for any services. But if somebody does have insurance, when we send them in for their labs or for their medication, we do have that done through insurance to save costs there.
So the state actually, by code, requires the counties be responsible for it. Traditionally, we've spent far more than the contribution from the county on this. The recognition that we have is that the distinction we make in public health is that we're not in the business of individual health, we're in the business of not having community spread. But TB is one of those very specific areas where the intervention at the individual level changes the direction of the spread so dramatically that that's why we take it so seriously. Also, it's dead, so it's that. But that's why we do it. And we also anticipate every budget year additional monies for this very issue. If we have a dramatic increase, we'll have the assets. So we never have to open up the budget again.
Gotcha. Thank you. Sorry.
And we do get a lot of help, even though it's a small amount per month through this program called Sure here, which is HIPAA compliant video direct observation therapy. So we don't have to go out to individuals' houses every single day once they're stable on their medication. That is funded by the state, which seems like a small monthly amount, but the amount that it saves in our resources for nursing staff and mileage is huge. If we didn't have that system, I would, being down nurses and just the funding alone, it would be very challenging for us.
Yeah, it saves thousands of dollars just to be able to look at somebody over the phone and do that therapy over the phone versus driving out to Mountain or wherever it may be.
Yes, so we benchmarked that years ago because of the dramatic cost, but also the reality that because we have such a large geographic area, our staff were out of the office, and so they weren't being effective in other areas of public service. By changing to an electronic directly observed therapy model, we have dramatically reduced staff time and cost. It would be an obscene amount of money with the current number that we have if we were doing it, and I dare say we wouldn't be able to keep up. So we're very fortunate for the advances we've made. Thank you.
And we have had one new TB case since we met last month. However, not related to our outbreak that's currently going on. This is completely separate. And I will say that it's been a few months since we've had any new cases related to that outbreak, which is always a good sign. I think I owe a lot of appreciation to our local health care providers and our hospitals who have been very diligent on doing diagnostics in the hospitals who are actually diagnosing these patients, which we're seeing a lot more cases, but I think normally these may have been missed or delayed and we would have had even more cases. So we've worked really closely with our hospitals, and I would say it's a pretty big team happening right now. So.
And I would tell you this, I mean, TB is one of those diseases that every dollar spent is really more money saved. Because not treating them leads to more cases and you just spend more. So this is money spent that's really well spent, and therefore you're going to spend less in the long run.
The testing the hospital does, is that like comes at admittance or it comes with symptoms?
It comes with symptoms. Usually if they're showing up at the hospital, they've got a severe cough, they've got weight loss, they've got night sweats, but you can do a chest x-ray and say, oh, that's pneumonia. But without doing further testing and more assessments, and we've seen where it gets diagnosed as pneumonia, they come back in a month later, still having symptoms. Antibiotics helped for a week, but then their symptoms came back. So there's some of our hospitals now just have a protocol. They come in with these symptoms, we're screening for, we're doing a workup for TB.
Yeah,
if they have
unfortunately,
these
we're
risk
all becoming
factors.
TB experts, whether they want to or not. They're becoming TB experts.
And Madam Chair, if I may recognize also Melissa's leadership in this. This is a strategic partnership that she's created over many years. The commitment with line staff at Tribe, and certainly working with clear communication, transparency of effort, always being available. We've created our provider resource website, which allows for real-time sharing of information to clinicians. It's a dramatic change in terms of our commitment to a larger partnership that happens, which I think is different than in other counties. So my hats off to Melissa.
Next thing I'll speak about is the Pride Festival was on Saturday. The Akron Health District did attend that. We gave out information on STIs, sexually transmitted infections, as well as PrEP services, which is a medication you take to prevent from getting HIV for those at high risk. And then we also provided information on our testing services that we do at the health district. And then lastly, with the new recommendations that came out for COVID vaccines, specifically with Robert Kennedy, the Washington State Department of Health, our state health officer, Dr. Tal Get, had sent out some recommendations that came from the Washington State Vaccine Advisory Committee that Washington State will be continuing to recommend vaccines for anyone age over six months of age, including healthy individuals. And so us at the Akron Health District will continue to follow the state recommendations in regards to the COVID vaccine. Any questions?
I have a question about TB, and I was wondering if there's any variation from month to month.
It does. We usually see between 5 to 10 cases a year for active tuberculosis. The last 12 months, we've seen an increase in our cases dramatically, partly because of an outbreak. Some of it is still residual from COVID-19 with delay in treatment, people not having access to care. And so with latent TB, you can have latent TB for an extended period of time and not know you even have TB, and then it can become active. And so I think we're seeing a lot of people who didn't have access to care during that time. Thank you.
So are we still doing twice a week, the harm reduction unit,
Correct.
City of Yakima, Toppenish?
We do Toppenish on Tuesdays and Yakima on Thursdays.
Can you give a ballpark figure for the average cost to treat TB for the health district for what a single patient? Do you have a feel for that?
Goodness, it really varies. I would say this last year we've had an increase in cost specifically because we've had a new interim health officer who's also had to learn TB. We've had new staff who've had to learn TB. So there's definitely been more hands for learning because our TB nurse will be leaving at the end of the year. And so we've had a lot of training with new staff. Chase, do you have an idea?
I mean, I would say this, Don, it's pretty easy. You have the pharmaceutical cost, and then you have manpower cost, and then you have backstocking, reorder, et cetera costs. So you can break it down that way. I don't have a number for you, but I can say it's significant because when you think about that, all those have a chunk to them. Yeah.
Yes, you've got, obviously, for the first significant period of time that observation has to be done in person. So there's significant staff investment in that process to ensure that the medication the individual is taking is not having an adverse effect.
And
I
it
sound like a
really
nurse.
varies. You do. And it really varies on the individual and how many resources they have. Do they have transportation?
Right.
Can they get to us? Do we need to go to them? Do they have a primary care doctor? Are we going to have to manage all of these side effects they're having, or can we let their primary care doctor do that? So there's just, do they have income? You know, is food a barrier because now they can't go out and get groceries because they're in isolation? I mean,
Right.
there's just a lot of variables with each patient that has to be considered.
It almost seems unfortunately to have gone like TB finds the most vulnerable and just annihilates them. It is ruthless. And I know the organism is thinking, but you're talking about, you know, people with developmental delays. You're talking about people with lack of access to transportation. You're talking about people who live isolated. There's a lot of educational and language barriers that we face. And so with all of that, you're like, man, this is a problem. And because this is complicated, if you had all your wherewithal, and it's really complicated when you don't. And so we have to supplement and get out there and say, listen, this seems like overkill, but it's necessary overkill in your particular instance.
And I'm sorry to continue to add to this, but I wanted to share that we're very service forward here at the health district. Some of the people that we find, as Dr. Atteberry indicated, that are living in the lower valley are working or isolating in circumstances that are not often ideal. So we go out of our way to find them and accommodate them because, again, being asked to be seen day in, day out by a professional is not an easy endeavor. And we try to be very flexible to accommodate their lives, their circumstances, but that takes time and effort, which also places pressure on our team. But that's really about being available to the community on their level, not what's easiest for us. So that does take more time and more cost.
When you have a daily contact with this, say by phone, do they initiate that or do you initiate that?
The one that we're currently using is, it's recorded. So they can go on and we made sure it was that way so it's convenient for them in case they're working 12-hour shifts, 7 days a week. They can go on at a time that's convenient for them. They record it, upload it, and then our nurses or team will review it the next day.
And so the minute they miss one, now they're getting flagged and they're like, find what happened. You know.
Which we do. When they miss, then we have to find out what happened. Did you run out of minutes on your phone? Did you, is there a reason why you didn't take your medication?
Did your dog eat your homework?
Do you find that to be problematic? Are there people that just don't follow through?
There are. We actually have one that's just missed 3 or 4 days, and so we were in the process of figuring out why, and it was because they ran out of minutes on their phone. Because it's a financial barrier when you're missing work because you're in isolation and you can't afford the phone. So then we work with those individuals. Maybe they're not a prime person to be on video DOT. So then we have to determine, is this somebody who meets the criteria to be on video, or can we help by getting what we call loaner phone, where we're able to do a prepaid phone to be able to, is that more cost saving than going out there every day?
Any other questions from us at this point? Is there anyone here?
Stands allowed to ask questions.
Well, at this point, we're kind of past public comment.
I didn't even know.
No, I appreciate that. You spoke up earlier, appreciate that. Okay, Melissa, is there anything else?
No, that was it.
Any questions from Melissa? All right, hearing none, we're gonna move on to environmental health with Shawn Magee.
Where you get everybody. So, starting with the tracking of food when we have these, multi-state recalls on food products. We locally here, we rely on what's called the Foodborne Illness Notification System, or FINS. That tracks individual complaints and tracks recalls on food products from manufacturers and distribution centers. And the nice thing is, technology has been implemented in this, that every pallet of food product or every carton of food product that comes out of a distribution center or a manufacturing facility is labeled with a batch number. And, that batch number has a range. This was produced on this day, and the next day it's a new batch number. So they know, and they even further break that down. Okay, these eggs are from this farm, these eggs are from this farm. That if there was ever an issue like salmonella, they know specifically what eggs are contaminated and where those eggs went, and that facility can reach out to the retailers and say, you need to pull this off the shelf. Our role in that is when we get a recall notice, we will touch base with those retailers, make sure they're aware of the recall, and we can go in and make sure that that product's been pulled. So when we have been involved, or there's food product in our county that's been recalled, by the time we get there, they've been notified and it's been pulled, or by the time we even call, they've been notified and it's been pulled. So we see real quick turnaround when these issues of contaminated food hit the shelves. They get pulled very quickly. So it's a real effective way to track this and to minimize any foodborne illness outbreaks. So
Does the health district make posts, any kind of communication if the public's already bought said eggs or product?
I don't know if we have.
No, it typically, because at the federal level, they'll post not that way, but we don't individually set those out.
Right.
So there's no notice that goes out to the public that says.
Not from the health.
Not from the health district.
There is from the federal government.
Is that delayed?
Well, I'm just saying, if we identify like Safeway locally,
Yeah.
would we as a health district step in and tag the federals to say, oh, make sure Yakima, this is hitting our local community?
I don't know why we wouldn't just post it ourselves.
Yeah. That,
Oh, we
kind
could.
of what I was thinking.
What's interesting is actually that because you've got national chains, they are absolutely hyper aware of this issue. And so we have found that that information is, as Shawn indicated, blanketed in the community. But we do weigh in when you have something like a Chipotle outbreak that is ongoing and of concern. And if there are actual local apprehensions about that, we have been involved in that. But normally these things come out, we check it quickly, and most of the time these issues don't affect us because we've already been notified that we have not received that produce. But yes, we weighed in when it's of ongoing
When it's
concern.
local, that makes the difference, but typically that hasn't been the case.
I just wouldn't want to be a person that got eggs from California. I didn't know.
Exactly. I'm with you. Yes.
Often, just as a side note on that, the manufacturer will label under 10 other labels. So oftentimes you'll see, well, there's a recall on company X. You're like, oh, I don't have company X, I have company Y, but in fact, that's a label of company X. So that's a real problematic thing. But these lot numbers are universal. So they're.
Dr. Ivory, that's not making us feel better.
Yeah, no, I'm just saying like.
Thank you, Lisa.
Yes.
On a more personal note, things such as eggs, avoid sunny side up and overeating, right? Cook them thoroughly.
That's the best way.
I know, it is the best way, but it's also the riskiest.
Hard boil those babies.
So next, sticking with the topic of food safety, we continue to respond to unlicensed food vendors. There's ongoing coordination with YPD in that effort. They're moving around a lot more now, so it's hard to establish a pattern of where they're going to be on any given night. But okay, is it 40th and uphill?
It's on uphill, but it's not right.
Okay. All right. Anyway, we're out there. We're looking. We're going to be trying to set something up again with the detectives division with YPD. In addition to that, this is just exploded into an entire statewide issue. It's driven a lot of the conversations at several of the statewide environmental health directors meetings and conferences that I've been in, and it's recognized by the state that there needs to be some cross-jurisdictional efforts here. Some methods that other jurisdictions are taking are not successful, some are. And instead of just being on a Zoom call and kind of just sharing what works and what doesn't, start, documenting that. And also the State Department of Health is in discussion with the Assistant Attorney General on what can be done at the state level around this issue. Because, it's a pretty egregious violation of state regulations around retail food safety. And, we all want to get it taken care of and have a food vending safe for the public, and safety is comes at a lot higher level when we know the facility's been permitted and inspected, and we know and they know that they're doing the right thing as far as food service.
Shawn, has there been any discussion with these, at least in Yakima County, not at the state level, but with these pop-ups occurring more frequently, and putting out a cautionary warning to community members, just saying, hey, we applaud those that are, that these are the things you should be looking for. Look for the permit to be posted, or make sure you're looking, so that we're educating the community. They may just pull up and assume that they have all the proper permitting and they're following procedures. But I personally would like to know, if I was a part of this Board of Health, I probably would be unaware.
Mm-hmm. Yeah, and that's in development. I know that other jurisdictions have put out public communication. It's gone largely ignored, but I'm sure it helps. It makes some people aware and helps them make a decision. What we're noticing is kind of a loyalty following of these particular vendors that they're growing on social media. And when we go to address the issue out in the field and have them close down for the evening, we explain why they still don't agree with us. So
I think you might be surprised at how many people follow, because we had the same pushback, like, why are you sending out the OD map spike alerts? And people thought, oh, that's not really. Every single time we've done it, we've had every imaginable media reach out. We've had people call. I had my Northwest HIDA officer said she saw an article from the Sunnyside Sun in Banff about it. And so it definitely gains more traction than I think even we are aware. And I certainly don't think it's going to cause harm to do it. And it doesn't take a lot of time to create it and then repeat it if we're seeing it. Just as a regular cycle, you can schedule it on a social media calendar and have it hit and tag certain organizations out there.
Yeah, Shawn, maybe I should suggest we do a taco action network.
Yes.
You want to lead it?
And we'll tag the Floridians. Yes.
Well, I've actually talked to somebody who has a son who loves to go around all the community and find all these little places. And it's a big deal to him. He'll try every taco truck or everything, and sharing the information. They said, well, I make a difference to him. But if I were a parent or if I were an individual, I would certainly want to know whether or not people had the ability to wash their hands.
Yes.
While they're preparing food, or after they prepare food, or after they use a facility, or they even have one. The handling food.
They don't have either.
Yeah.
Alicia, we can applaud those who are doing the right thing.
Yes.
And keeping our community safe, because they know this is happening, and those small businesses are concerned because they're following rules, they're spending.
Yes.
To protect their clientele, so we can certainly elevate that.
So Shawn, we talked about this last month, and it's been weighing on me because there was the comment made that I don't know what percentage of these folks tie back to a large criminal organization in California that's exploiting and taking advantage of a vulnerable population. And I don't know if that's why the state is now engaged, or if it truly is just, you know,
I think that's part of it.
good intended people just not getting their.
Because the vehicles they were using did go back to the registered owners being.
But see, that's a different message though, that when you send out to the community, if you tell the community, don't support these pop-up taco stands because they are exploiting a vulnerable population, that's a different message than, you know, the health.
But since then, they've even, they started using, like daily rental U-Haul vans. So we can't run license plates. It's getting more complicated.
Well, you know, kind of piggybacking what Andre said, there is something I think we owe to the people who are actually trying to follow the rules and do it the right way. You know, because they get impacted by these, you know, by these businesses or entities that aren't following the rules. So I think part of the effort is to appreciate, respect, and defend.
And we do similar things at Safe, like we do compliance checks to find out, you know, if there's vendors that are selling liquor to minors. We don't, you know, produce a list and say, aha, you're caught. We applaud those that say congratulations to these organizations that passed.
And I think including information that would allow any individual who read it to say, okay, I'm gonna eat at this taco truck. How do I make sure it's legitimate? And, you know, look for the license, look for the necessary and proper. It's education and outreach.
It's prevention.
So.
Yes, I agree. I wouldn't know if a business was required to post their license or not, or can I ask to see it or not? And so feeling empowered to know that, I think helps.
I think it'd be interesting to do on social media, for example, from the health district, to publish, you know, like 5 to 10 businesses a week. Hey, these businesses are, you know, have passed all the tests, are legitimate. We encourage you to shop there, so to speak. We encourage people to shop local. So, I mean, it just would be interesting to see if we get a response. And I think that the people who are paying to get, you know, approval and going to classes and doing all the right things would appreciate that. And I know I would if I were in their place. So it's something easily done on social media through the health district.
Is there I'm assuming that all that's public information, right? Is there a link you can click in to say these are the ones that are?
That's amazing.
We
and alphabetize them.
Publish our inspection results from all the different facilities we've inspected on our website.
I think the issue is you have a couple of bad actors that are and probably thousands of great actors, and so we want to make sure we capture the bad actors. But ultimately, it would be thousands of people that are being compliant. You know, so that's it's hard to say, well, which 5 are you going to pick? Most of them.
Well, that's what I was thinking, the link, you know, then they can click like applaud and support these businesses that are permitting and, you know, hiring the right, you know, going through the correct processes and making sure that our community is safe by following.
And I think making it easy for the public to do that. Like in a Facebook post, to put the link in rather than saying going to our website and do this and do this. Because as soon as I hear go to the website and do this and do this, I'm already checking out. I want to link. I'm serious.
It might be weird, but I do look at every restaurant I go to for the sticker on the wall. I do, but I mean, I clearly am weird. So
Well, and you have the knowledge to do so.
Yeah,
right?
right.
Whereas the average consumer probably does not.
Shawn, just throwing this out there, I mean, the health district, we are able to assess fines on folks that are in violation, right? Because I remember
we do have an operating without a permit for our temporary food vendors. In that we can't assess that fee, but with these particular vendors, they won't even come in and have a conversation.
Yeah, just so there's no way for us as a health district to say, you know, moving forward, we're gonna have $1,000 fine that we're able to assess on anyone that doesn't, I mean, because that would be a loud message to comply, right? Versus.
Except that I think that obviously they don't care. And they'll just find another corner to pop up on, and because they're going to talk about it.
The city of Yakima is issuing citations.
Because we don't really have authority other than at the time of being inspected, paying fees, that kind of thing. We don't have authority to really
collect.
So we really
The
like
health
it.
district doesn't.
Yeah. And I will share, for the vast majority of people we come in contact with, those who don't know how to do something become compliant quickly. Those who maybe were cutting quarters become quite prepared to do the right thing. They value the work they do. They have pride in what they do. This is a targeted operation which has caught the entire state and other regions of the country by surprise. It's a business model based on evading oversight and cutting corners that put people at risk. So this is something that from a portfolio standpoint is new for us. It's new for the city codes. It's new for the police. I mean, you have police officers saying, I've never heard of this being an issue before. It hasn't been an issue. Right? So this is really something we're going to have to invest our time in. And to the point that was made earlier about the support we receive from the federal government or the state in terms of all kinds of things, recalls and so forth, we have to remain more vigilant now because we can't rely on people doing it for us. That system is not built and there's not as many people interested. So that's why we're trying to be more robust and work with our local partners because it's prevalent and we see that. And in fairness, these places are targeted. I mean, places that have hardworking people who make a modest salary are targeted for things like late night food that's very inexpensive and easily accessible. This isn't an issue in Bellevue, it's an issue here. So that's where we have to remain vigilant on behalf of the community.
And just would like to say that we're very grateful for the support from YPD and the city and everybody involved. There's a lot of local health jurisdictions that don't see the same kind of support. So, we feel very, very fortunate in that regard. The last thing I'll talk about is the DTG limited purpose landfill. We did deny their extension of operations. They did not meet the deadline for excavating the temporary fill area, which has a vulnerable aquifer directly underneath it. They're predicting that they will have that cell completely excavated and the waste moved onto the lined phase 2 cell by end of July. So this was a permit condition that they agreed to. Again, they asked for 5 months, we gave them 6, and they didn't meet that deadline. So we made the decision to deny that extension, and we'll have them excavate that cell. We did notice that their operations for excavating that cell went from about 4 or 5 trucks being active in that effort to 10. So
Imagine that.
So, it is what it is, but we'll stay in communication with them. We're in communication with the Akron County Solid Waste, and I believe they have some capabilities to accept some of that deterred waste that would go to DTG at the Shane landfill for a short time. So we're in an okay spot with that, but it is our goal as soon as DTG is back in compliance with their permit conditions, we'll get that.
And if they don't meet July deadline, I assume
There's no deadline on now. It's go as fast as they can because they want to open again. So,
all right.
That's quite an incentive.
That's an incentive, that's right. I applaud you guys for saying no.
I guess I'll add, the Cajun limited purpose landfill is still shut down. We haven't heard anything from them recently. So I think they're working through the issues they have with their land use permit county, and then they're working with Department of Ecology on some things. So. All for me.
Any questions for Ms. Magee? If not, we will move on. Thank you, Shawn. To public health partnerships with Lilian and Bravo.
Yes, thank you. So this month we'll be wrapping up our partnership with NAMI, which I've been referencing over the last year. That again is the National Association of Mental Illness. The majority of that partnership focused on workshops and trainings for organizations that have providers that work with families, so different adults or youth mentors, people that fit that category. However, a portion of that training was also dedicated to addressing provider burnout. And for that, last month I had mentioned that we were going to be offering 2 separate workshops, one online, one in person, one specifically for comprehensive healthcare actually. And so with that, we were able to provide this training to 64 individuals individuals that included different therapists, counselors, corrections officers. And the whole purpose of that training was to help these providers who work with those with mental illness and substance use issues to help better understand what their clients are going through, because a lot of times in this field, you do see that burnout and seeing the clients that you're trying to help continue to go down this path. And so from the people that participated, they received it very well, and it's something that the providers found helpful, and we hope to expand upon next year. It was just a small portion of the training, but I will be presenting on the results of the overall training, the workshops with the community and different organizations, including this provider, in the upcoming months now that we have all the data so we can evaluate it. My second update is related to communication. So as this month, we'll also be concluding our two substance use prevention campaigns. Again, the youth-based campaign with neighborhood health services, which was Escape. And then the second one that was focused on adults and caregivers, which is Connect to Prevent. With those ending this month, we'll be focusing in the summer, working more on internal issues. So looking at our compliance to the ADA Act. There's a couple different initiatives that need to be completed by next spring in terms of making sure that all of our content is accessible. So we'll be working on that. Also, with that work, looking at taking another look at our website to make sure it's cleaned up. Honestly, we have some learning to do in terms of how to make sure that everything's clear and straightforward, so that when you get that Facebook post, it goes straight to the link. You don't have to click 5 different ways to get there, because that's where you lose people. And then finally, we'll also be exploring newsletters to make sure that all the work that's taking place can get promoted. And I'm sure a large portion of that portfolio will be related to environmental. Any questions?
I know the campaigns are haven't concluded yet, but like when we look at it like next month, like what do we consider a successful campaign? Is it like the number of clicks or whatever through our website, or?
Yeah, so currently the metrics for a successful campaign would be who looked at the website, how many people looked at the videos that were posted on YouTube, how many positive comments did we receive, or anyone that reached out. So there's a component of quantitative and qualitative. However, it's really mostly just awareness at this point. I do think that moving forward, related to substance use prevention, specifically the workshops and the work that we've been doing in the community, is going to be a bigger focus now that we have the message out there. It's more important to get actual resources out to people that are tangible, not just a message.
Yeah.
And I would like to encourage moving forward on the campaigns, particularly with prevention, that we definitely want to make sure it's evidence-based. Commissioner McKinney had asked me to attend the meeting with Yakima Neighborhood Health Services, and I was hoping she'd be here today. She and I met because I was able to meet with the Yakima Board of Health, or excuse me, the State Board of Health, as well as with our providers at CADCA. And unfortunately, with the escape, there was concern because of fear tactics. So despite the fact that there were peers and it was peer-led, the messaging at the top was opioids kill, and that is not evidence-based. So at the bottom, it'll say that hope still exists, or there's still hope. And so my recommendations after meeting with them is the message should be that. Opioids kill is obviously not going to resonate. It's going to create fear, and actually fear tactics can make the problem worse. There's evidence, there's several articles that indicate that. So I shared with Commissioner McKinney all of the messaging that I received back from Department of Health, the articles that support all that. So just moving forward, we want to make sure that we're not causing more harm than good, and that it is evidence-based practices.
Thank you for sharing that. That is one of the pieces that was discussed during the meeting, as I reported back on. One of the some of the context as to why that term specifically was utilized, just for reference, was given the population that we were serving and wanting to reach. These are individuals that likely already have utilized substances or have peers that did. However, to Alicia's point, that is something that we're going to be moving forward to implement, is making sure that we're taking that step to look at evidence, make sure that everything's getting reviewed beforehand, that way these concerns are addressed earlier rather than after materials have been developed.
Right, exactly.
Alicia, I guess I just would ask you, it seems ironic to me that the term opioids kill is not evidence-based. Opioids do in fact kill people. So what would be non-evidence-based about that?
So evidence-based would be that message should come from parents and caregivers. but not from campaign messaging from nonprofit organizations. So,
Got it, okay. Not that opioids don't in fact kill.
so there's actually several articles about what works in prevention, what doesn't work. The healthcare authority produces that document. I've shared it with every single one of the commissioners. I've shared it with city council members. And basically it's building skills, citing consequences, positive social norms that the overwhelming majority of youth and adults don't use substances. Those are considered evidence-based. It's a very small micro niche when you're dealing with youth. So, and the concern is obviously when you have a campaign that is broadly out there, you're going to have youth that are going to see that, right? Regardless if they're the target market or not. And elevated risk is elevated risk. It doesn't matter if it's LGBTQ+, it doesn't matter if they're unhoused, it doesn't matter if they've used substances in the past. It all boils down to adverse childhood experiences, and these youth are at risk. And so we have several brochures that say opioids kill. These are the things to look for with methamphetamines, but we provide those to the parents to say it is important. You're the primary caregiver. You are the trusted adult. You're the #1 protective factor. You should be having the short and frequent conversations about the risks and your strong disapproval of these substances. It should not be coming from Safe Yakima Valley. It shouldn't be coming from the health district, etc. The message that should go to the parents. For the youth, we should have one of those, what works in prevention. And the concern is dosage. So oftentimes what you'll see with the fear tactics, like the dropping off of the car that's crashed because Johnny was drinking and driving, in the very short term, you'll see a reduction in behavior, but as you measure it, the youth will say, oh, well, I know several people that drove drunk, and they almost look at it as a challenge. And so you actually see the behavior escalate after the fact. Same thing with suicide prevention. If you have someone come in and talk to a group of youth about, I survived a suicide prevention attempt, they look at it and go, look at this person being paraded around, and all the recognition they take, and you actually see the opposite effect. And the ironic thing is when you include peers and you say, what do you think works? The majority of youth will tell you fear tactics. You need to be brutally honest. They will tell you that, but the data shows otherwise. So it's important to have dosage. So when you look at skill building, like popping life skills, they don't just have one and done lesson. It's dosage, and they have to have the opportunity to practice the skills. So the drug resistance skills, the goal setting, etc. Elementary, it's 8 lessons. Middle school, it's 15 lessons. High school, it's 10 lessons. When you look at a positive social norms campaign, it is bombarding them with several media rotating every 2 weeks with that messaging about the positive social norm for an entire year. And so it's about dosage with youth. And we want to make sure that it's a message of hope, that it's not something of fear, that hope is available. I think at the bottom it says it's never too late. And so I just suggested, well, why don't we flip the narrative and say it's never too late? Because the goal is we want them to go to the site to find out that there's healthier alternatives to dealing with their anxiety, depression, their issues, whatever they're experiencing.
So Alicia, what you're saying when you talk about evidence-based, it's not really saying whether a fact is true or not. Is that the effective way to deliver the message to get results?
And then it seems to be all workers in the mental health arena and that are working with healthcare and drug addicted patients. We all know, or it's the least kept secret, that child molestation leads to these behaviors. Predominantly, we see lots and lots of this, and yet I haven't seen any campaigns that suggest that. Is there a reason for that? Is it a bad topic?
There's just no information out there about that, and how to. I think the other thing, to your point earlier, is it becomes more and more difficult to have. How do you prove that evidence is working? You know, how do you prove its legitimacy? Because you're going to have a test group, right? And then the one that receives the no intervention. So how are you going to do that ethically?
Yeah, right.
So it's going to be very difficult to say that definitively this works. Whereas with life skills training in the 80s, they said, oh, easy. Okay, this group is going to get life skills. This group's not. Let's study them over the next 12 years and see what happens. Today, if we tried that in a school and said, hey, we're going to allow you to not give any prevention to these kiddos, and we're going to give the prevention, the life skills just to these kiddos, everybody be up in arms, right? So it's very difficult in today's environment. So the best you're gonna get instead of model plus or model recommendations is that it potentially might be effective. It's gonna be real difficult moving forward to say definitively. And I'm guessing that's why. And given child molestation, it's a dicey subject. Nobody's probably delved into it.
Yep. Lilian, is there anything else? Any other questions for Lilian? If not, we're gonna move on. Thank you. We're going to Community Programs Director Gabby Alvarez.
Good morning, everyone. So we are currently working on contract amendments for both breast and cervical health and developmental disabilities. We're also wrapping up our developmental disabilities audits with our vendors because we will be audited by DDA, which is Developmental Disabilities Administration, later this summer. Also in developmental disabilities program, we have been working intensively to engage in schools around the Yakima County, including Granger, Natchez, West Valley, and Sela. And after ongoing efforts to get these districts on board, we are now seeing an increase in interest, and they have beginning to reach out more about our Job Foundations program. And in other news, the Healthcare Authority recently learned that their Centers of Medicare and Medicaid Services shared Apple Health enrollee data with other federal agencies, including immigration enforcement, without their consent. So this impacts about 1.7 million Washingtonians, and it raises serious concerns about the misuse of this protected health information. HCA did release a statement reviewing possible actions and remains committed to protecting the privacy of healthcare clients. This situation has affected our breast and cervical health program directly. We have been asked to share this information with our clinics, and we understand that this news may cause a lot of fear and concern with the patient seeking care because we believe that if patients seeking care are afraid, they might not attend to their appointments. This may cause our screenings to go down, which may affect our cancer detections to go unnoticed. Unless there's any questions, I conclude my report.
Was that a data breach or was it intentional?
It wasn't intentional, and it wasn't also a data breach. It's kind of hard to explain.
But not intentionally.
It's federal information that should be protected by law, but wasn't protected by law. And so it was shared, but it is considered both a breach and their privileged information. So it's not our information, it's not the state's information, it's actually federal data.
And did I hear you correctly, Gabby, that the Yakima Health District asked to be sharing this?
No.
Oh, okay.
The Department of Health asked us to share this information with our clinics.
Oh, okay. I thought you meant like.
No.
Oh, to share. I was like, oh my stars, someone's calling and asking you to share.
No.
Okay.
Oh gosh, no. We're trying to communicate real time, like you said. There's been a problem.
The clinics actually reached out to Department of Health wanting more information on what was going on, and they just DOH asked us to share the statement that HCA released with our clinics and the clinics that we're contracted with for PCCHP.
Have you guys seen any impacts at this point?
Not yet. This is very recent. But like I said, we do expect screening to go down just because people are feared to even go to a doctor's appointment. I don't only think that this will impact our PCCHP program. I believe as a whole, people are just going to be afraid to go to their doctor's appointment. So I'm guessing we'll see. If we see some changes, I can bring those up.
The dollars that we use for the screening program, those are state dollars, those aren't federal dollars.
It's a mixture. Yeah. Currently, it's actually majority federal. Yep.
Yeah, because we get funded by CDC.
Yeah, that may change in the next come July, but at the moment, it's mostly federal dollars supporting CHP.
Any further questions? If not, thank you, Gabby. We appreciate that. And we're going to move on to item 8, which is new business, which is a standard agenda item. So if you have new business to discuss, we have none brought to our attention today. We'll move on. We've added a new agenda item, number 9. What happened? Oh, that was mine. It's in my head earlier. Okay, sorry about that. We do have unfinished business tonight, which is the local health officer candidate interview selection. Our goal is to continue delivering the health officer services. So Dr. Atteberry is our interim, and we will go through an application and interview process for a health officer. We have some options in that. How many applicants do we have at this point?
Yeah, so we do have a process in place for the health officer appointment, outlined in Board of County Commissioners Ordinance number 3-2022. And so the first part of that process is to advertise for the position. So we did advertise in we put out a provider alert to all providers in Yakima County. It's been posted on our website and also in social media. We advertised in the Yakima Herald. We sent notices to the Yakima Neighborhood Health Services, the Yakima Farm Workers Clinic, Pacific Northwest University, and Multi-Care. And so we did receive applications or resumes for 2 candidates, Dr. Atteberry and Dr. Maxwell. So it kind of makes it easy on the board for the next process, which is to interview candidates.
Has the time closed for applications?
Yes, time
So we
closed
have
on
just
Monday.
2 applicants then, right? So we have some options as a board. One is to move ahead with interviews like we've had in the past. But however, we need to recognize that both Dr. Atteberry and Dr. Maxwell have been through this process at least once and maybe twice. And we'd be asking the same questions unless new questions come up. So there's a suggestion that the interviews that they had previously were filmed, send those back out to the board to look at the interviews.
So we did talk to our attorney yesterday about this, and he said since there is a process in place, we need to follow it. Yeah, that was it.
We can't, if I make that, I mean, we couldn't make the decision to pivot from that process and make a designation today, allowing a potential seat to be open so that, because the commissioners don't appoint the health official, it's this board, yeah.
Well, and we've also asked the same questions, so you could ask different questions. But again, the lawyer indicated that we had to go through a formal process. So we couldn't just be vetted from the last information. I think, but that formality was the board's decision.
Yeah, that was our attorney's.
But you do have background information already.
Yes, we do.
So
we might change the questions to make it easier for the applicants. If we do use pre-recorded applications or previous interviews from previously, we might reduce the number of questions and give the applicants more pointed time to present themselves.
Or we could establish a subcommittee to do the interviews and put forward a recommendation for the health board to consider.
Yeah, and so what we've done in the past, we have that committee. It's been the board chair, vice chair, and then a citizen member where we do interviews. Myself included, do interviews, record it, and then send it out to the board so they can view it before the next board meeting, and then make an appointment at the next board meeting. Recordings.
If we, and you're correct, that's part of the process, what we do. So my thought is with the subcommittee, whoever's on the subcommittee, the questions this time would be briefer and giving the applicants more time to advocate for themselves. And then send both recordings, formal previous interview where they're asked all the same questions, and then the new interview where they have more time to advocate for that questions.
So both candidates have been interviewed twice. Once was in July of 2021, which our attorney was, that was a long time ago. And then that was when Dr. Barr became health officer. And then also back in August of last year when we were advertising for the reserve health officer. Again, the same two candidates also went through this process. So 10 months ago. So that was the only concern is there's been some time that's passed since those two.
Board discussion?
I would just hate for them to have to go through a third interview. And I mean, everyone around the table is very aware of the resumes and interviews and whatnot. So but if the guidance is to stick to that process, then okay.
Well, for example, Alicia was on the board previously when that occurred. Anybody else on the board who's not experienced that before? Not seen the interview? Yeah.
Ryan's point of clarification, is there going to be a health officer and a reserve health officer, two positions, or a singular position? I just.
Yeah, so we did talk to the attorney about that, and there is no outline for the process for the reserve health officer. So it's up to the board how they want to move forward on health officer. Candidates, there could be a possibility of one health officer, one reserve health officer. Or board can go and say, let's go advertise again for a reserve health officer. So it's up to the board how we want to move forward on the reserve health officer part.
For the health officer part, right? You said the word reserve.
Reserve.
Well, to add complexity, we currently have a reserve health officer who is a board member serving as an interim health officer. Thank you, Dr. Atteberry. So depending on whom you choose, you could have a new health officer and a reserve health officer who remains a board member, or you could have a new health officer and have a vacant board position and a vacant reserve health officer position. Again, the board decided to not use a state health officer as a backup in the event of an emergency or planned vacation. So we still have two positions, but by statute, the only position that is defined is the health officer, not the reserve officer, which.
That's our own decision here.
Correct. Correct.
Which in retrospect is really smart because they got rid of the state reserve, or the state officer. So we looked at brilliant.
So again, there's a lot riding on the decision. To be supportive of the board, the previous plan to have a committee allowed for a more expedient process and less scheduling and less time for the board. It was also a smaller venue for the applicants to speak freely. So again, it's up to the board if you wish to have a formal presentation with every board member, but if we have all the board members, then it's a public meeting. Whereas if it's a committee, it's not a public meeting. I think I'm doing justice.
I think so. And that would be for both positions?
It's the board's choice.
Okay.
I think, I mean, the only one that has to be followed at this point is the health officer.
Well,
we could appoint them, we could choose to appoint a reserve health officer.
Correct.
To contract with the reserve health officer.
Well, I guess for discussion for the board, I would be in support of moving forward with the intent of having a reserve officer. I think we heard from Dr. Bard, the reason we needed one, and he was doing, I don't know how many years he was doing it without one. So I think I would prefer to keep that moving forward. So with that being said, I think one of the questions that need to be asked of the candidates is, if not selected, are you willing to serve as a reserve officer capacity so that this board can know that we have a primary and secondary? There's also a part of me that's like, can the board not make a decision today so that should a selection come in, now we have a vacant board position so that we can start advertising candidates, because otherwise it'll be December before we have a full board again. So
yes, and thank you for the clarification, Commissioner. We had a board member who became our reserve health officer, but that is not going to be the case if one of our two candidates is selected. So you will have an open board position, you will have a reserve health officer position, and you will have an appointment as the actual health officer. So that's just a consideration that impacts our quorums. But again, that's the reason that happened was the unique circumstance of a sitting board member becoming reserve health officer, which you will not have. Okay, it's a lot.
It is a lot. Any suggestions from the board?
There was discussion around the candidates like advocating for themselves in another interview. And I just had one suggestion to like maybe include some scenario-based questions or ethical questions where like you can kind of see like where the interviewer would like to take their point to, even though there's like no clear answer.
Thank you for that.
I would move that we proceed and create the subcommittee as we've done for protocol, with an eye towards selecting not just the health officer, but the reserve health officer as well as part of the process.
I will second for discussion. I don't know who was the citizen member that served on it last cycle. Are they intending to serve? Are you?
No, it kind of depends, I guess. When it is, or, you know, how it works out.
Probably shoot for not next week, week after. For the.
We're not 4th of July week.
Yeah.
Yeah, any citizen. So in the past, we had the chair, the vice chair, and then a citizen member. So we have four citizen members, obviously, one staff can't do it. And so that leaves three citizen members, they won't be on the board. Or we can just do two. You two are interested.
That might be easier just for coordination, you know, kind of like you pointed out, I mean, this is sort of just theater at this point.
Yeah.
It's not like we really need involvement. Just going through the process.
I'm good with the committee of two.
Yeah, keep it simple.
Are you joining the?
No.
Well, and in fairness to the commissioners, you can't have two commissioners. They
Oh, it
have
gets
their own
complicated,
board.
true.
Yes.
I was gonna kick
No,
Ladonna.
no. And also, if I may, this is, while we may have gone through the process before, this is a new process.
Yes, it
Because
is.
we're talking about both positions being considered, whereas that was not the case the last go around. The interview was solely for health officer. So this is quite unique. And
So are you saying that, so how would it work if Dr. Maxwell gets appointed, then would Dr. Atteberry stay in his current board position and reserve health officer?
that would be the board's decision, but that could be one of the scenarios.
That would be my understanding, because that's been kind of our practice
Yeah,
currently.
just kind of keep things, okay.
Is that you could be
So-
a board member serving in a reserve capacity. You just can't be a board member serving as the health official. Yeah.
Right,
So
because you can't be delivering reports from the dais and be a voting member of the.
Right. Yeah, I just wanted to clarify when you were talking about how we would have the scenario of each position being up for
Yes,
being open, but not necessarily depending on the decision.
Sure. And again, my respects to Dr. Atteberry, who's been sitting in multiple positions today. It's not easy to talk about things that impact your own choices, but I would say philosophically that it is better to have a board member who is solely a board member than also a staff member, because I think it does create complexity. And Dr. Atteberry's been very diplomatic about it, but it does create scenarios that may not work out well in terms of direction or choices, especially if you're in an emergent situation. Because again, just let's be real, if we were in an emergency right now, Dr. Atteberry would be acting as our health officer only. If you were not able to have a quorum, that would be an issue. There are reasons why we make a differentiation between a board member and staff member. But given that, it's worked out, it's just complex.
I would agree that, you know, similar to why we wanted the person to be a Yakima resident, having that sectioned off so there is no conflict of interest is probably in the best interest of the Board of Health.
But in fairness, Dr. Atteberry is serving a term, so it's, I think, unfair to ask him to change a term.
Right.
And also, in fairness to our previous work with legal counsel, there's nothing that defines an interim or a reserve health officer position, only a health officer position. So.
Yes, but if he becomes health officer, he can no longer fulfill his term.
Correct, that
Yes.
is clear in terms of the statewide statute, but not for a reserve health officer. And certainly not for a city board member being elevated to the position. It's where we set new ground in Yakima every day.
So we had a motion by Commissioner Lindy to form a subcommittee to do the interviews, and it was seconded by Commissioner Curtis. Not defining the number on that board, does that make a difference?
I don't think so at this point. I think consensus would be it's a committee of two.
I'd ask that committee of three with Ryan, if you don't mind.
Right.
No, that's fine.
I would let it
Thank you.
So we have a motion and a second, it's been discussed. We'll take a.
Mayor Byers, could I just make sure everyone's aware that Captain Poston is back there?
Oh.
So for voting.
Should you join us at the table? You are on the board. Right.
That's my understanding.
Thank you for noticing that. I don't have ice in the back of my head. Great. Thank you for joining us. The whole time. You haven't long your hair, so.
During the presentation.
Okay.
It's been a while.
Thank you. All right, so all those in favor, please say aye.
Aye.
Any opposed? All right, motion passes and we will move forward. I do want to
Chairman, I
encourage,
just want to make sure it's clear I abstained.
thank you.
Thanks.
One abstention. Who's taking records? Thank you. Yes, and Dr. Atteberry abstained.
Oh, Dr. Lupita, I don't know if she's.
Lupita's online, I don't know if she.
Lupita, did you, I didn't hear anything. Did you say something?
I said aye.
So we have a majority vote, one abstention. And so I just want to encourage Mr. Ibach and Mr. Fresco that we come up with some brief questions with including some scenarios that we might like to ask about and a way to ask the applicants to advocate for themselves in that. And then all that will be sent up to the board.
Regarding willingness to serve in your position.
Yeah, that should be one of the questions. Okay. Any other discussion on that matter? Hearing that.
I just would add one thing if I could. As I mentioned to several of you before, I think, if selected as the health officer, then I would resign my position as the board member to clarify all those points that were brought up earlier. I believe it's actually fairly simple for the reserve health officer to be a board member, actually, because they don't have to do the reporting. It's really very rare that they're conflicted. So, thank you.
Thank you. All right. Now we're going back to item 9, which is a new item on the agenda. We put this here because in a perfect example, and Alicia, I thank you, you opened a whole broad topic of conversation, right? And so we put in this other item so that if we have people that want to open up the conversation, a particular topic, ask more questions, longer discussion, that we bring it to the end of the meeting rather than in the middle of the reports. So does that make sense to everybody? Because it can oftentimes be a little disruptive in progress report for all that to one at once. So thank you for being a perfect example today, and I loved your discussion. So come when you have another, when you really want to open things up to the board and provide some education to the board to hold on to the end and bring it in under the other discussion. Questions about that? Okay, then we move on. Is there any other business, by the way? You may come with anything today. All right, so it's a good time if you have other things that have not been discussed even in the report and you want them on the agenda, then you can notify Andre or Mr. Ibach and it will be brought under new business. But if there is none and something comes up in the course of the conversation or you come in with something, then that goes to other business.
Yes, I may clarify. New business often was about something that people wish to vote on. So we had a very specific process for that. I think other business are these concerns that we're having, which are large scale community concerns that are quite complicated, like limited purpose landfills and having issues with unlicensed food vending that may have a repercussion that people are concerned about. These are large scale issues that we may not be able to address in the next month or two, but may be long-term considerations. So it's not necessarily a board vote, but it is awareness. And it's certainly something that's important to all of you. So we want to make certain that it has a platform.
I guess the delineation would be, since the topic was brought up about a specific campaign, that would seem like an appropriate time to say that for that particular item. It would seem weird to me to put that as new business since we just talked about that campaign.
It wouldn't be new at the end, rather. You can wrap me up at the end. Coming back to anything the board wants to talk about at length. That's just going to be real no final answers for it today, or just a broad educational piece.
I don't think there's anything wrong with that, the topic being brought up, as you say, but then if it's obviously becoming a broader discussion, that can then wait till a component of the meeting now, so that it's almost a placeholder for this larger discussion. Because again, one of the things that our staff try to do is to update the board on real-time issues that they find pertinent. We don't want to stop that, but I have noticed that there are times when the conversations robust, which is wonderful, but it's actually we've lost the direction of the actual report, which we don't want. So it's just a place for these kinds of discussions because it's of interest. And obviously, if people have more interest in it, it becomes a larger conversation, which is wonderful.
So in the event, like when Dr. Atteberry asked the question, that's where we would say, carry that to the end of the meeting, because I was simply answering his question. So I just want to clarify that. Okay.
Well, if I may, I think when I first joined the board, it seems like our agendas were extremely tight in the sense that if you wanted to bring forward an item, you had to wait till the end and request to add it to a future agenda. We're pivoting from that. Now, we are having an open-ended opportunity to just throw anything on the table and have a discussion. So, and I welcome that. I think that will allow us to bring items that, are on our mind. For example, if I can use this opportunity, I mean, are we seeing less overdoses in our county? Because I think the national media claims that we're seeing less and less overdoses, and I don't know that I necessarily feel that that's the reality.
Well, we tend to lag behind the East Coast, so we normally tend to be several months behind the East Coast because the influx of new, of the chemicals to make, for example, fentanyl come on the East Coast, ports from China, then they get distributed north and south, and then up. Obviously, we've seen the impacts of fentanyl. The distribution lines have been severely impacted. They've been reduced significantly. But that being said, there has obviously still been supplies that they're disseminating. They're cutting them differently. That's where we saw carfentanil, which has been confirmed in Yakima County, which is very newsworthy. The DEA in the West in Seattle didn't even know that. Like, it was news to them. And so there's these sporadic. We are, if you talk to the coroner last month, they'd say we're trending down, and then you can have one spike and suddenly we're back up again. And so it's just a very much so a moving target. And I think Melissa could attribute that to, and we're with Andy and looking at the data. It's just.
And we're definitely watching, we're seeing an increase in methamphetamine use, likely because of the borders being tightened up. So what's able to be manufactured here versus being brought in. So there might be a transition. So you're obviously going to see less overdoses because it's a lot easier to overdose on opioids. It's more acute, sudden versus methamphetamine is more over time.
Yep. That's a report we've gotten from our chief of police as well, is that there's an increase in methamphetamine. And that's, where a lot of the focus is right now. And it is easier to make here. And so, but it's caused a reduction in the fentanyl because the supply has been cut off. So the prices on that are actually going up. So it's more attractive for some people to be using meth. So it's just like you say, Alicia.
Yeah. I mean, a month ago during our meeting, remember we had 31 overdoses in a week.
Yep.
And fortunately, only 2 of those were fatal. I mean, 2 is still too many, but it could have been a heck of a lot worse because that was carfentanil. And so, and then we do an OD task force meeting with Board of Health led by Andy. And for the month of June, we had been significantly downward. And it followed this pattern last year where we were like, oh, hey, yay, awesome. June, July, August, we kind of saw a downtick and we were like, oh, maybe we're finally seeing it. And then boom, in September, October, we saw October was a record month. For the
Does that usually come with a change in the cutting and what they're blending with?
We don't, I think that we just don't have enough data to identify that pattern. That again, there's so many dynamics that are moving now. We've got a closed border. So how's that going to look different, this September, October? Moving target.
In terms of methamphetamine.
So meth, right, they're seeing is, they call it speedballing. So they still are doing meth and fentanyl when they can. But the prevalence of meth is definitely increasing, as is cocaine. And they're in the Seattle area, they are seeing a lot of people who think that they are getting cocaine, and in reality it's fentanyl. And so they're snorting a line and it's fentanyl, and it's obviously immediately lethal.
I also would add that in the report that I read, the state of Washington based showed that though the numbers might be trending in a downward way, the disadvantaged community representation of those numbers is going in the opposite direction, so that the least among us are overdosing at a higher rate. That they are overrepresented by their number. So Native Americans, minority communities are seeing higher overdose rates as compared to other populations, which is also disturbing.
Well, the other thing that we have to remember, Kyle, is that with ODMAP, we're seeing that we're experiencing still very high numbers of overdoses, but Narcan and first responders are getting very good at saving lives. So that's the other factor, is we still aren't measuring the entire magnitude across the country. So they're saying these are the number of overdose deaths, but they're still not tracking. How many overdoses are we still responding to? How many times has Johnny overdosed? Whereas maybe 2 years ago, Johnny would die because we didn't have enough Narcan. It wasn't out in the community readily available. We didn't have leave behind programs. We didn't have never use alone phone calls. We didn't have first responders trained as well as they're trained. And so there's still a lag there across the country in terms of measuring the non-fatal overdoses.
The street commerce is really complex, and that as was indicated, if the price of one drug goes very high and something else is inexpensive, that's what people will veer towards. It's not, this is not boutique drug use. This is what can I afford to use because I have an addiction. And the other reality with that is that some of these other things like meth are highly addictive. So our concern years ago was, if you take this drug, you may die immediately. The reality is that it's no less of a concern in a sense that someone might become addicted to a drug that is so highly addicted and so dramatically hard on the body that their lives are changed dramatically. And even people who come through addiction, as I understand it, their health has been imperiled because of that drug use, but also the threat or the vice of addiction is something that they live with daily for the rest of their lives because brain chemicals have changed. So the issue in our community, I think, is appropriate from Dr. Atteberry's perspective. We have a problem here, and regardless of the drug that is used, the problem is still here and has to be addressed, and that's a larger conversation. But I want to also thank the board for their understanding about why we want to put this other business on here. It's to have these serious conversations. As board members, you're public health leaders in our community, and also as we have our conversations, other things come up that spark discussion. So its place at the end is not meaning it has less value. It's actually quite the opposite. And frankly, to respect your time, if we had an incredibly robust conversation and then had to have board reports, or rather staff reports, the meeting might go long for you. So we're just trying to balance everything so that there's a place for the sentiment of our board members.
Any other comments or questions for any other business today by the board? Okay, well then, hearing none, I would entertain a motion to adjourn. So we have motion and second to adjourn to our next Board of Health meeting on July 30th, 2025. All those in agreement say aye.
Aye.
I hear you, Lupita. I don't think so. Okay, Lupita's been down, my breath is gonna go. Thank you. Thank you for a great discussion today. Thank you everybody for being here.
Thank you both for sharing.